हो जाएगा।
छोड़ दे, जाने दे।
एक हो जाएगा, वो लाइव हो गया है, ये तो अपनी तरफ से हम करेंगे।
उधर से सही।
Are we ready?
Yes, sir. Yes, sir. We can start now.
Will we start?
Yes, sir.
Okay. Good evening, everyone. Welcome to the 6th master class of Jaipur Surgical Tutorial. Jaipur Surgical Tutorial is an online educational activity conducted by the Mahatma Gandhi Medical College Hospital in Jaipur. We conduct a session every Saturday, 9 to 10 India time in the morning. And the master classes are done every last Thursday and Friday of the month, 7 to 9 p.m. both days, 2 days. So those of you who are still not members of the Jaipur Surgical Tutorial, please send your details, that is the name, institution, city and country, to Dr. Anand Nagar, my colleague who is an associate professor of HPB surgery and liver transplant at my institution. That's his number. He is the coordinator of the Jaipur Surgical Tutorial. We also conduct another weekly session, which is every Friday, 3 to 4 p.m. This is primarily for colleagues in Africa because they cannot join the Saturday morning, but anybody else is also welcome to join Jaipur Surgical School. And this is coordinated by Dr. Kailash Kurdia, who's my colleague at AIMS New Delhi. That's his WhatsApp number. So please send your details to him. So these master classes, as I said, we've already conducted 5 master classes, and today's master class today and tomorrow is on liver space occupying lesion, which is a frequent clinical problem. To moderate this master class, I have requested 2 of my very eminent colleagues, Dr. Vivek Saraswat, who's the chief of hepatology at my institution in Jaipur, and we have worked together for more than 30 long years at the SGPGI Lucknow before coming to Jaipur, and Dr. Naimish Mehta. Dr. Naimish, maybe you can, he's the director of the Center for Digestive Sciences and chief of HPB surgery and liver transplant at my institution. And before joining us, he was the chief of transplant program at the Sir Gangaram Hospital. So I think I now hand over to Dr. Saraswat and Dr. Naimish.
Well, good evening, everyone. Good to have you on the 6th masterclass. Dr. Kapoor has given you the background. Liver SOLs are a common clinical problem, and approaching them primarily is based on the imaging Although, of course, the first is the clinical evaluation and assessment. So accordingly, we have 4 speakers this evening. Dr. Anand Nagar is going to talk to you about the various kinds of clinical presentations and the etiologies of space-occupying lesions. Then there will be Dr. Heera, and I think as we come along and they come along, I'll introduce each one of them, who will be talking to you about ultrasound imaging. Dr. Sanyukta, again, from radiology from Mahatma Gandhi, will be speaking to you about CT and MRI. And finally, our very good friend and senior colleague, Dr. Sanjay Gambhir, who is the professor of nuclear medicine at the Sanjay Gandhi Postgraduate Institute, who will be speaking to you about the role of the nuclear physician and nuclear medicine imaging in SOL's management. I'd request Professor Naimish Mehta to please introduce Dr. Anand Nagar, and let's get going with the first presentation.
So I would like to welcome Dr. Anand Nagar, who is the Associate Professor of HPB Surgery and Liver Transplant at Mahatma Gandhi Medical College and Hospital. He has been working there since more than 5 years, very well experienced in HPB surgery. He is going to speak to us on liver SOL. What are the causes of liver SOL? How do we approach that patient? And how do we manage? Over to Dr. Anand Nagar, please.
Good evening, respected faculties and my dear colleague. The topic was allotted me to causes of liver SOL. Basically, it is an overview of different type of liver SOLs. It doesn't include the management part. I will give you the basic overview, and it is very difficult to cover the symptoms or the many etiology of the liver SOL in the single session. So basically, I will give you some overview of my liver SOLs. So I will discuss my topic in the headings of introduction. Types of liver space occupying lesion. They can be cystic, solid, benign, malignant, histological classification, single or multiple. And at last, I will give you the summary. My talk will not include any investigation, which is further included by my subsequent speakers. And it doesn't include also management part. And so coming to the introduction of my session, increasing use of the radiological imaging leads to increasing diagnosis of incidentallomas. It causes great concern to patient and the physician. Symptoms usually unlikely due to lesions. Increasing cost of additional imaging which turns out to be futile. Some benign tumor do not require treatment, while it is difficult to differentiate few benign lesions on imaging from the malignant ones. Clinical circumstances like age, gender, use of oral contraceptive pills, history of chronic liver disease, and recent travel may provide clues to the etiology. The presence of underlying chronic liver disease, either suspected or proven by clinical and/or laboratory features, as well as the time of detection of the mass, provide a different dimension to the nature and the relevance of lesion. A mass lesion seen in hepatitis B or C infection, which may not be associated with chronic liver disease, there is always suspicion of malignancy. Coming to my topic allotted, the different type of liver space occupying lesions. They can be cystic or solid. The cystic lesions can be because of parasitic or non-parasitic. Parasitic cause includes hydrated disease, and the non-parasitic cause includes benign. The benign causes include simple cyst, polycystic liver disease, biliary cyst adenoma. They can be because of trauma like bilioma or seroma. They can be because of malignancy because of biliary cyst adenocarcinoma. They can be solid maybe because of inflammatory or neoplastic. Inflammatory includes abscess. They can be because of pyogenic or amoebic abscess. Neoplastic may be because of benign and malignant. And the benign, when we talk about the benign causes, benign solid lesions are hemangioma, hepatic adenoma, and the focal nodular hyperplasia. In the malignant category, we includes either primary disease or secondary liver disease. Primary liver malignant lesions are hepatocellular carcinoma, intrahepatic cholangiocarcinoma, hepatoblastoma. Other uncommon primary malignancies are fibrosarcoma, angiosarcoma, leiomyosarcoma, and lymphoma. And the malignant category includes secondary. Secondaries are the most common solid liver space occupying lesions. They can be hypo or hypervascular. Most common primary for liver secondaries are from colorectal malignancy. They can be from other sources like lung, gallbladder, pancreas, stomach, breast, and ovary. They can also be classified as the histological classification, as the name previously included. They can be arise from the either hepatocellular lesions, bile duct lesions, which I have explained previously, biliary hematoma, cystic or polycystic liver disease, hydrate disease, bilioma, and the miscellaneous causes also include abscess also is there. And these lesions can also be classified as the lesion is single or the multiple. And the single lesions can be on the basis of ultrasound, which can detect either solid or cystic. Cystic lesions discussed previously. The solid lesion further classified on the basis of CT, MRI, and the tumor markers. They can be same malignant and the benign. And malignant category includes hepatocellular carcinoma, intrahepatic cholangiocarcinoma, METS. The benign category includes hemangioma, focal nodular hyperplasia, adenoma, biliary cyst adenoma, and some uncertain diagnosis. When we have multiple lesions in the liver, they can be categorized as solid or cystic on the basis of further imaging and the form of CT, MR, and tumor markers. They can also be classified as metastasis, multicentric hepatocellular carcinoma, regenerative nodules, abscesses, hemangioma, adenoma, cystic METS, or the polycystic liver disease. So in the summary of my presentation, most of the liver SOLs are benign without underlying liver disease and require proper evaluation to rule out the malignant lesions. Proper use of radiological imaging and technical aspects of CT, MR are important in the management of liver SOLs. As my further subsequent speakers will be talking regarding the use of ultrasound to differentiate the different liver lesions and use of CT and MRI to detect to differentiate the these lesions will be discussed in subsequent presentation. Thank you.
Thank you, Dr. Nagar, for an excellent overview of liver SOL. Do we have any questions?
Yeah, Himanshi, maybe you can take the questions from the chat and put it on our chat box so that we can get them. In the meantime, Anand, I will ask you that out of all the ones which you have mentioned, can you mention what are the common ones as far as the cystic and solid lesions are concerned?
Most common cystic lesion is hemangioma and the simple cyst. And the most common solid lesion are the METs. As the liver, when we discuss about this, the most common solid lesions are the METs in the liver.
So I think among the cystic lesions, it's worth mentioning that simple cysts can often be confused with hydatid cysts. See, I mean, you haven't talked, maybe somebody in the imaging might talk. There is this Gerby classification of type 1 to type 5 cysts for hydatid cysts. And the type 1 is a unilocular simple cyst, which can easily be confused with plain ordinary simple cysts, which are often congenital malformations, and although their management will differ. So cystic lesions, as you rightly said, one would have to think of simple cysts of the liver and possibly parasitic cysts of the liver. And then there are these other cystadenoma that you mentioned. Those would also be important. And generally, you are quite right that the solid lesions are the most common. And of course, metastatic. Depending on the kind of population you are looking at, amongst us, we'll see a lot of liver disease patients and solid lesions in the liver in a person with liver disease or with liver cirrhosis Hepatocellular carcinoma immediately comes to mind. Maybe Professor Mehta would like to add some other remarks on these lesions.
No, you have, I think, covered, and Anand has covered a fair bit. But if you see a single solitary lesion in a female, then your diagnosis, your probable diagnosis will be different. So you want to just enlighten on that, Dr. Anand, between, if suppose you see it in a female, what will be the diagnosis in younger age group, female in an older age group, similarly compared to male and in younger and older age group?
So when we talk about the young female, which is the more we can think of adenoma is the diagnosis which comes in our mind when we take a history. Maybe probably there is a history of oral contraceptive pills intake, or maybe is there. So we can think of adenoma, hepatic adenoma, as a diagnosis in the young female. So as the Saraswat sir told regarding the different cystic lesions, so further, my colleague Dr. Heera will be taking the point on the ultrasound. Will be differentiate different lesions. So the on the workup part will be taken by the Dr. Heera. So I haven't included so many things in my presentation. Only the overview of our liver as well is included.
So from the student's point of view, if you see a cystic lesion, as Dr. Saraswat pointed out, if you see a single unilocular cyst, it is virtually impossible to differentiate between a simple cyst and a type 1 hydrated cyst, unless you see some sand or a detached membrane, which I'm sure the radiologists will deal with, that which will be the best modality. So that is one dilemma which usually in clinical practice you have. On the other hand, if you have a multilocular cystic lesion, sometimes it becomes difficult to differentiate between a hydrated with daughter cysts versus a biliary cystadenoma. So these are two clinical or imaging conundrums which we face, and I'm sure our radiology colleagues will deal with that in more detail.
Regarding sir, just to add, regarding sir biliary cyst adenoma and biliary cyst adenocarcinoma, many of time we are in thought process of the patient is having biliary cyst adenocarcinoma, but after doing the surgery and the biopsy comes out to be cyst adenoma only. Maybe in spite of imaging features, we are not able to get this right diagnosis on the same time.
And second dilemma which one faces is when you have a underlying chronic liver disease and then you have a space occupying lesion, you don't know whether it is part of the cirrhotic process, a regenerative nodule, or whether it is a malignancy. So that is another issue which I am sure we will discuss more in detail once we have dealt with the radiology of these lesions.
So shall we move on to the next presentation in the sequence?
Yeah, I think we can. Yeah.
Okay, I don't see any two questions
Anand
coming
or
into the
Dr.
chat
Naimish
box yet.
want to say something?
Maybe. Okay, so I think I'll invite Dr. Heera Ram now. Dr. Heera Ram is Assistant Professor of Interventional Radiology at the Mahatma Gandhi Institute. He has trained in radio diagnosis at the Aurobindo Institute in Indore, followed by a fellowship in interventional radiology at the Medanta Hospital in Gurgaon. And his area of interests are hepatobiliary interventions and oncology interventions. He is a member of several Indian and international intervention radiology societies, and he's very active in terms of interventional procedures. So Dr. Heera will be talking to us about the role of ultrasound, which is generally the first imaging modality one resorts to in the setting of a suspected liver space occupying lesion. So over to you, Dr. Heera. Please share your screen and tell us about ultrasound evaluation. Thank you.
Before Heera starts his presentation, I have to add that although today he is talking on ultrasound, but his forte is interventional radiology, and he and Dr. Nikhil Bansal, his other colleague in interventional radiology, they are a very strong support to GI surgery, HPB surgery, and liver transplant. So we are very fortunate to have two very
Capable
well-qualified,
interventional
well-experienced,
radiologists.
and expert interventional radiologists. Yes.
Thank
Welcome,
you.
Gambhir. Welcome.
Hi,
Thank you.
Sanjay.
Thank you, sir.
Yeah, please share your screen.
Thank you so much, sir. And special thank to Dr. V.K. Kapoor, sir, giving me this opportunity to speak on ultrasound role in the liver as well. Although ultrasound is a screening tool because it's readily available, it's cheap, and again, it's a very good modality to diagnose. It's a radiation free. So quickly, let's talk about the ultrasound evaluation of the liver as well. Now, already Dr. Anand sir told about the classification of liver masses. So I'm not going into detail of this. Liver lesions can be divided into cystic, solid, and then in the parasitic, non-parasitic, parasitic divided into hydatid, and then non-parasitic, there can be simple cyst, there can be polycystic disease, there can be biliary cystadenoma. Solid lesions can be inflammatory, which include pyogenic and amoebic liver abscess. And in the tumor part, it can be benign or malignant. In benign, it can be hemangioma, adenoma, FNH, and in the malignant, it can be SCC or secondaries. Now, first, let's talk about the cystic lesions. In the cystic, the most common lesion we encountered again in the insidadenoma is the simple hepatic cyst. Simple hepatic cyst, usually they are small lesions. They don't cause any problem to the patient. They are asymptomatic, and they are on the ultrasound. If you see, they are well marginated with internal anechoic content, and you can't appreciate the wall. And because of the anechoic content, you can see there is a posterior acoustic enhancement. And on the CT, you can see CT or MRI part, I'm not going to talk, but you can confirm on the CT. But generally, simple hepatitis does not require further imaging if you are confident with diagnosis, and if you know that all the characteristic feature of simple cyst on the ultrasound are available. Although the simple cyst can be sometimes they are a big cyst, and they can complicate with internal hemorrhage, they can be complicated with superimposed infection, then they definitely we require further imaging. But a typical simple cyst is small 2 to 5 centimeter lesions, and they are thin walled cyst. Now I am going to talk about the large cyst, and they have the spectrum of appearance. Here in the first image, you can see there is a large cyst with thin walled and internal homogeneous content and with posterior acoustic enhancement. That means the cyst has internal hemorrhage in it. In the B image, again, thin walled cyst, well defined, but there are multiple internal septae in it. That shows that this is organized thrombus in the simple cyst. In the C part, which is virtually looks like solid lesion, but is well-defined lesion. So in this, on the ultrasound, we cannot say whether this is cystic or solid lesion. So this definitely require CT scan for further imaging. On the CT scan, you can see this is thin wall, well-defined with internal cystic content in it. So sometimes cyst with internal organized clots look like solid lesions. So definitely then we require further imaging. Now next is hydatid liver cyst. Hydatid liver cyst usually in accidentally found in on the routine ultrasound. The small hydatid cyst does not cause any problems to the patient. Now, as the sir told about the garbage classification, I am going to talk about detail of this garbage classification of cyst. In type 1 cyst is a pure fluid collected cyst, which can be confused with simple cyst. But on the ultrasound, if you see the wall of the cyst wall is thicker than the simple cyst, as we know that simple cyst has imperceptible wall. But hydatid cysts are thick walled, although they are well defined with internal anechoic content, but the wall is thick. Type 2 has a fluid collection with the split wall, and they are look like floating membranes. So on ultrasound, you can very well see the floating membranes. Type 3 reveals the fluid collection with multiple internal septae, look like honeycombing. They have multiple daughters in it. So again, this is the classical finding of hydrated cyst, and you can definitely diagnose this on ultrasound. Type 4 has a heterogeneous ecogenic patterns, and in the type 5, because of the wall has calcification, so on the ultrasound, they have the reflecting wall, posterior acoustic shadow on the in the type 5 of hydrated cyst. Now let's talk about the detail of spectrum of appearance of the hydrated cyst. In the first, which is the most common hydrated cyst appearance on the ultrasound, has thick wall cyst with multiple internal daughter cyst in it, which is the classical of hydrated cyst. Now, in the B image, you can see, which is garbage type 1, is a thick wall with internal content. So in the, how you differentiate from simple cyst and type 1 hydrated cyst? So you can differentiate the wall. Usually, simple cyst does not have wall, they have imperceptible wall, but in the hydrated cyst, you can appreciate the thick wall. On the basis of this, you can definitely tell that this is not a simple cyst. This looks like hydrated cyst. In the D image, again, you see there is a mass-like lesion, but if you see closely, then you can see there are a small ring-like structure in it. And on color Doppler, there is no color on demonstrable color. And these all the mass-like lesion, they are all the debris in it, and on the operation, they came out to be innumerable scoliosis. In the image, you can see there is a well-defined mass with calcification in the wall, and there is posterior acoustic shadow. On the CT scan corresponding image shows that the wall is calcified. So again, you can see that this is most likely the hydrated cyst. In the G image, you see there's a calcified wall, this internal finger-like projection in it. So this is again classical of hydrated cyst. In the H image, you can see there is a central punctate-like calcification with again wall calcification, thick wall calcification in the posterior wall and with posterior acoustic shadow. So these are the various spectrum of appearance of hydrated cyst. Next is,
excuse me, Dr. Heera, before you go off, and if you don't mind, maybe it'll be good to keep asking questions in between. At the end, we tend to lose track. So you've
Yeah,
taught
sure,
us
sir.
about the cystic lesions, but type 3 onwards, type 2 or 3 onwards, they what you've shown are mostly have a solid looking appearance.
Yes,
There's
sir.
hardly any fluid. So hydrated cyst can be a differential for solid lesions also.
Yes, but if you closely look, like this D image, although this look like solid, but if you closely look them, then they can have
Fluid component.
yeah, yes, and then ring like, and those all on color Doppler, no vascularity. If you see that there is a wall calcification, then you suspect that this is hydrated. But on ultrasound, we cannot give the final diagnosis. We
Right.
have to go for further
Differential.
imaging.
Differential.
Yes.
We have talked about cystic hydrated disease, that is echinococcus granulosus, which is what we see in our country and
Yes.
most parts of the world. I think
Yes.
in Kashmir and in Central Asia, you also see the alveolar hydrated echinococcus alveolaris. So,
Yes.
would you like to say a couple of words or sentences about what is the sonographic appearance of the alveolar hydrated cyst?
So definitely they also have the on ultrasound we cannot say that this is alveolar or what, because the appearance looks almost similar, it depend on the internal content of the particular hydrated cyst. So this is
Right.
difficult on
It mimics the
ultrasound.
solid appearance, the type 3, type 4, unilocular or multilocular, and more of a solid rather than a fluid component in
Yes,
alveolar
yes.
hydrated. Okay, sorry for the interruption. Please go on.
And also, if I'm correct, they have a more infiltrating like appearance rather than a well circumscribed appearance.
Yes.
Yeah, you're right.
Yes.
Quite right.
Please carry on. Please carry on.
And this is the typical. I am talking about the typical hydrated cyst appearance, but hydrated cyst can be multiple. They can be in spleen, they can be in liver, and in liver there can be multiple hydrated cysts also, and then they can be disseminated also. So they have a variegated appearance. But most common hydrated cyst looks. I mean, if they have internal daughter cyst, then it's a classical finding. Otherwise, they sometimes difficult to differentiate. Now, talk about the liver abscess. Liver abscess can be, as Dr. Anand said, that can be pyogenic or amoebic, but on ultrasound, it's difficult to tell that whether it's pyogenic or amoebic liver abscess. So etiology of liver abscesses can be from the biliary tract. It can be infection from the GIT spreading via the portal vein. It can be hematogenous spread via the hepatic artery, can be direct extension from an intra-abdominal infection. It can be post-traumatic and cryptogenic also. So now I'm going to talk about the ultrasound findings of liver abscesses. Liver abscesses sometimes give you the challenge to diagnose on ultrasound if patient comes early. So usually liver abscesses diagnosis in US is just screening, but if you appreciate with the clinical finding with the ultrasound, then it's easy for us to diagnose this. Liver abscesses can have multiple variable appearances. It can be hypoechoic, which is more common, but it can be hyperechoic if there is internal echoes. Some liver abscesses has gas bubbles if the causative organism is gas producing organism. And on color Doppler, there is absence of vascularity. This is how we differentiate it from the mass. Now, again, these are the spectrum of appearances of liver abscesses. In first and second image, you see this is the same patient image. In the first image, when the patient came to us, then this is ill-defined mass, hypoechoic, relatively hypoechoic lesion, but we can't say this is the liver abscess. Only the clinical symptoms can say that, okay, this patient comes with fever and right hypochondrium, pain. Then on ultrasound, because there is no liquefaction in the abscess, so this look like solid abscess. But after 24 hours, there is partial liquefaction. So now we can tell that, okay, this might be abscess. And the other finding on ultrasound can be no demonstrable vascularity in the abscess. In the third image, again, is a mass-like lesion, hypoechoic mass-like lesion, which is compressing on the capsule and on the adjacent kidney. On color Doppler, there is no vascularity, but this look like mass. And again, this is the only screening part. Sometimes in liver abscesses, which are sometimes confusing, we need further imaging, which is CCT. So the classical finding of liver abscess is in the middle row. You can see there is a well-defined mass lesion with central liquefaction. On the color Doppler, there is no demonstrable vascularity. In the image, again, there is a well-defined large lesion with heterogeneous internal content and liquefied content in it. And in the F image is complete liquefaction of the liver with well-defined hypoechoic lesion. In the lower line, you can see there's a large, well-defined hypoechoic lesion with internal multiple echogenic content, which is confirmed on the CT scan that this is the gas-forming bacteria which causes the air in the abscess. In the typical abscess appearance, it's easy for us to diagnose on the ultrasound, but in the atypical findings of the liver abscesses, it sometimes is challenging to diagnose whether this is abscess or not. But if you correlate with clinical findings, then it's easy for us to diagnose.
So, I think, Dr. Heera, I think the other thing that probably is worth mentioning here is the multiple cholangitic abscesses in biliary tract disease or extrahepatic obstruction versus metastases. At times, you have a malignancy, pancreatic, biliary, gallbladder, along with multiple lesions within the liver. So
I'll
maybe
talk
say a word about.
metastasis. I'll talk cystic metastasis later in my slides.
Acha, okay, fine.
Yes, yes.
Then we look at it then.
Now let's come to next benign finding, which is polycystic liver disease. It can be associated with ADPKD and it can be sometimes isolated also. So ultrasound findings are, there are multiple, you can see on the ultrasound, there are multiple fluid-filled round or oval cyst with sharp margins. And we will differentiate later from other cystic lesion in the liver also. So usually they are multiple, they are fluid-filled, they are round, and they have sharp margins. And sometimes it may be difficult to identify vascular and biliary structure adjacent to the liver. So sometimes we require further imaging, I mean the CT or MR to differentiate. So this require differentiate from the hepatic cystadenoma. Hepatic cystadenoma differentiate from the polycystic disease by that they have well-defined anechoic content, but they have capsule in it. They have capsule and they have multiple internal septae. This is how we differentiate cystic cystadenoma, hepatic cystadenoma from the polycystic disease by the internal septation and the capsule. So this comes into the cystic lesions, and cystic metastasis I talk later in the metastatic disease. Now let's come to the solid liver lesions. And first we will come to the benign lesions. In benign, hepatic adenoma is more common. Specifically, the women who is taking the OCPs, young female patients, hepatic adenoma is more commonly found. On the ultrasound, the hepatic adenoma usually presents as a solitary, well-defined, heterogeneous mass, and echogenicity can be variable. Again, it is challenging. It depends on the how much fat it contains. If the hepatic adenoma contain more fat, then it looks echogenic. If it contains less fat, then it looks isoechoic or even hypoechoic. So in the 20 to 40% of the patient, the hepatic adenoma looks hypoechoic to the surrounding liver parenchyma, or approx 30% it looks hyperechoic because of the internal fat content. And sometimes because of the fat sparing, they have the hypoechoic halo. On color Doppler, it may show the perilesional sinusoidal vascularity. Here in the two different patients and two different images, we can see in the first image a well-defined hyperechoic lesion. And in the second image, you see there is a well-defined hyperechoic lesion with surrounding hypoechoic halo. That is because of the fat sparing. Now, hepatic adenoma, usually they are small, but they can be large and they can complicate with internal hemorrhage. Then we can face some challenges in diagnosis. In the first image, you can see a well-defined isoto-hypoechoic lesion with internal solid hypoechoic content in it. On color Doppler, no vascularity was found. In the second image, again, well-defined hyperechoic lesion with internal hyperechoic content. These both are patients who came with right hypochondrial pain. Patient when have these hepatic adenoma internal hemorrhage, then patient presents with acute right hypochondrium pain. On the CT scan, you can see that on the plain CT scan, there is a hyperdense internal content. On the contrast enhanced CT, you see there is no internal enhancement. So this is confirmed diagnosis that there is hepatic adenoma with internal hemorrhage. Another patient, you see there is a hyperechoic, well-defined hyperechoic lesion with a hypoechoic halo surrounding in it. And on color Doppler, you can see peripheral demonstrable vascularity. Next is liver hemangioma, which is a very common tumor of liver. They are incidentally found. They usually small, more than less than 5 centimeters in size. They don't cause any symptoms. if lesions, they can be large giant hemangiomas and which requires even embolization. So here in the first image, you can see well demarcated hyperechoic lesion, well demarcated hyperechoic lesion, and in the C image you can see large well defined mass with with hyperechoic content in it. So these are a classical finding of hemangioma, but hemangioma sometimes they can have cystic changes. They can be like atypical hemangioma, large hemangioma. Then we find very difficulties on ultrasound. Then definitely they require further triple phase CT imaging to differentiate, and they have very classical enhancement pattern on triple phase CT. They have peripheral nodular enhancement on a CT scan in the arterial phase. Then it's subsequently filling in. So they have centripetal filling in the late phase.
Dr. Heera, what would
Yes.
be the differential you would look for? You've showed us initially hypoechoic lesions and you spoke about them in the earlier slides. Now you have a hyperechoic SOL here, which you say is hemangioma. So is there any other differential for a hyperechoic single or multiple lesions in the liver?
Yes, sir.
that you'd like to
If
consider?
the lesions are well defined and usually hyperechoic, well defined small lesions, they are most commonly hemangioma. But the differential diagnosis is metastasis, echogenic metastasis. The metastasis which is hypervascular, they look if solitary metastasis, hypervascular metastasis, they look similar to this. But if we have primary, we know that this patient have primary, then we sometimes require further triple phase to rule out whether this is hemangioma or this is the METS.
Right. So then to differentiate between the differentials, you move ahead to second step imaging, which would be either CT or MR that we'll hear in the next presentation.
Yes, 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 sir.
So it would be good that in the hyperechoic, you just let us, each one of them, you let us know the differentials, because
Yes,
I think a sine qua non, something that is only definitely a particular specific lesion on ultrasound are few and far between.
yes, sir.
Maybe occasionally hydrated system, but the others you always have differentials for hypoechoic, hyperechoic solid lesions.
Yes, yes, sir. Now next we'll talk about the focal nodular hyperplasia. This is also very common, and again this is seen in the women associated with OCP uses, and usually FNH are less than 5 centimeter in size, and they can arise from right or left from any lobe. The echogenicity of both focal FNH and its scar is variable. It may be difficult to detect on ultrasound from the adjacent liver parenchyma. Some lesions are well marginated and easily seen, whereas others are isoechoic with surrounding liver. Detectable lesions characteristically demonstrate a central scar, but unfortunately, the central scar seen only in the 20% of the FNH. The central scar may seen on gray scale sonogram as a hypoechoic linear or stellate area with the central portion of the mass. On occasion, the scar may appear hyperechoic. Doppler ultrasound feature of FNS are highly suggestive in the well-developed peripheral and central blood vessels. They have very pattern of the vascular, which is a stellate type of pattern. So here, these are the appearances of FNH. In the first image, you see there is a almost iso to hyperechoic. You see, it's very difficult to appreciate with the adjacent parenchyma. So it's iso to hyperechoic lesion, but you can appreciate there is a central hypoechoic hypogenicity. On the color Doppler, you see there is a very patternable demonstrable vascularity, which is stellate arterial pattern. In the C image, you see there is a hypoechoic lesion. So in the first image is iso to hyper. In the C image, it's hypoechoic. But on color Doppler, in the grayscale imaging, you can't say this is FNH. But as soon as you put the color, this is diagnostic feature of FNH. You see this is a stellate pattern of vascularity. This is only seen in the FNH. In this image, again, grayscale image, it's well-defined isoechoic lesion, and which we can't say what it is. It can be even hepatic adenoma. But once you put the vascularity on it, again, it's a diagnostic. It is stellate type appearance of vascularity, which is characteristic of FNS. The FNS differential is hepatic adenoma, and final diagnosis is definitely for the hepatic adenoma is FNS or biopsy. But in FNS, we can diagnosis is on the triple phase, and if the stellate pattern of vascularity demonstrated on the ultrasound, then we can confidently say that this is FNH. Or
What you told us is, sorry, what you told us is that only in 20% where you have a clear-cut stellate scar on Doppler,
yes,
can the sonologist be fairly sure that this is FNH. 80% will be a differential of other solid lesions like
others like
FNH
hepatic
adenoma.
adenoma. Yes, hepatic adenoma is most close differential to the FNH.
Right.
Yeah, but nowadays we also do a contrast enhanced ultrasound CEUS. On the CEUS, the early phase arterial phase on in the FNS will enhance relative to the background lever. Typical focal nodular hyperplasia show early arterial centrifugal feeling. And CUS, I am not talking about in detail because Dr. Sanyukta will talk about the CUS and this CTMR findings. In the late arterial phase, they have centrifugal figure, which is opposed to hemangioma and adenoma. This is how we differentiate hemangioma and adenoma from the FNS. So FNS has centrifugal feeling, but in the hemangioma and adenoma, they have centripetal feeling. And in the portal venous phase, they have sustained enhancement in the portal venous phase, as opposed to adenoma, which is wash out in the later phase. Here you can see in the CUS ultrasound images, they have a typical centrifugal filling. So this is all about the common benign solid lesions of the liver. Now comes to the hepatocellular carcinoma, which is the malignant lesion, most common malignant primary malignancy of liver. SCC can be solitary tumor, they can be multiple nodular lesions, they can be diffusely infiltrative. So, and they have propensity to the venous invasion, specifically portal vein involvement can be seen approx 30 to 60% of the cases, and more often than the hepatic vein. Hepatic vein also can be involved, but portal vein are more commonly seen. Ultrasound findings, the sonographic appearance can be variable. SCC can be solitary, they can be multiple, they can be small nodular lesion, they can be multiple large lesions, they can be solitary large lesion, they can be cystic, they can have large, especially large lesion can have internal necrosis. So it's difficult to then diagnosis on the ultrasound, and they can be hypoechoic, they can be complex, they can be echogenic. If usually if the SCC are less than 5 centimeter, they are usually look hypoechoic on ultrasound. Now, the close differential for hypoechoic lesions, I can say that benign lesions, but they have the malignant lesions. They have irregular borders. While on the benign side of the lesion, you can see usually solitary lesions, well-defined lesions. Then they have more common of towards differential diagnosis towards the benign lesions. But if we see a nodular lesion and have background CLD changes and background nodular changes, then can more likely they can be SCC. So clinical finding and the background liver parenchyma is important to make differential of SCC. Otherwise, by looking on ultrasound alone, it's sometimes difficult. So usually the lesions which are less than 5 centimeter size, they can be hypoechoic with the liver. And if the lesions are more than 5 centimeter, and if the lesions are large lesion, they are very prone to have internal necrosis or fibrous changes. With time, they can have these changes. Calcification is very uncommon, so if virtually we can rule out if any lesion has internal calcification, then we can say that okay, this is not SCC, this is something else. This can be metastasis. Some metastasis can have internal calcification. Calcifications are very uncommon, but small tumors may appear diffusely hyperechoic, secondary to fatty metaphoresis or sinusoidal dilatation, making them indistinguishable from the fatty. So sometimes focal fatty infiltration also look like a lesion, but on then these type of lesion definitely require triple phase to rule out whether this is the focal fatty infiltration or this is the infiltrative SCC. So these are the BMOD grayscale findings. If the lesion are smaller lesion, they are usually nodular lesion. They have round shape. Their border are usually well defined. They can have hypoechoic hollow surrounding it. But if the lesion are large lesion, they have irregular shape. They can be very poorly defined. Then definitely it goes in favor of SCC. On color Doppler, small lesion difficult to demonstrate vascularity, but large lesion can be have very good internal vascularity. They can have pulsating arterial flow in it, so we can demonstrate it, and definitely we can confidently say, okay, this is malignant lesion. And final diagnosis is definitely SCC can be diagnosed on triple phase CT scan, or other lesion need histopathological imaging, which we require biopsy. We usually do biopsies which are indeterminate or non-diagnostic on the imaging, even though in the CT or MR. Now these are the spectrum of appearance of SCC. As I told you, they can be small lesion, they can be multiple, they can be solitary lesions. In the first image, there are multiple small hypoechoic lesions in the background of CLD changes. This is definitely in favor of SCC. In the B image, you see there is a background CLD with multiple hypoechoic lesions. Again, in the favor of SCC. These are the cirrhotic lesions. In the cirrhotic lesions, sometimes it's difficult to find if there are multiple small irregular nodular lesions. They can be also the nodular changes of liver, which we can say they can be LR1 nodule or what. So then we require triple phase CT to finally diagnose. Okay, they are not regenerative nodule, they are SCC. In the C image, as I told you that these lesions can be hyperechoic, like cystic, echogenic meds or SCC. And in the background, if we can't see any that much cirrhotic changes, but definitely it has changes. But this is mimicking of hemangioma. This requires triple phase CT scan to finally diagnose it. Because on the ultrasound, this can't, we can say that, okay, this is SCC, this is not hemangioma, or this is hemangioma, not SCC. Because sometimes it's confusing. This is solitary, small lesion, well-defined lesion, echogenic lesion. So this require the further imaging. In the D image, we can say, okay, there is ascites, CLD changes, and there is a large hyperechoic lesion in favor of SCC. In the E image, we can again say large lobulated lesion with mixed echogenicity, and there are multiple hypoechoic lesions in it. Then this is also suggestive of internal necrosis, and this is definitely a malignancy. In the F image, we can see there is a large lesion, ill-defined lesion with central hypoechoic scar. So this is a scar in the large lesion. But FNH is well-defined, usually small, well-defined lesion. So this can't be FNH. In the G image, we can see there is ill-defined mass with there is extensively soft tissue mass in the portal vein. In the H image, there is ascites, nodule, CLD changes, and there is background CLD changes, and there is exophytic lesion, exophytic hypoechoic lesion. So this is again, we can say that, okay, this is malignant CLD changes with malignancy. In the eye image, again, we can say that there is a large lesion with mixed type of echogenicity, and again, there can you can see the background, the echo texture is coarsen. So this is in favor of SCC.
Heera, I think another 3 minutes because we'll have to.
Yes,
leave
sir. Yes,
questions.
thanks. In again in the A image, you see there is a extensive thrombosis in the portal vein. There is a background CLT. There are multiple small hypoechoic lesions. On the color Doppler, you can see there is a aliasing vascularity in the lesion. So this is a PVTT. On the color Doppler, you can see there is a arterial enhancement in the portal vein. So this is definitely a PVTT, and it is confirmed on the triple phase CT. Now the final is metastatic liver disease. The most common primary tumor in the liver metastasis, they are from the gallbladder, colon, stomach, pancreas, breast, and lung. Most metastases to the liver are blood-borne through the hepatic artery or portal vein, but lymphatic spread can also be there from specifically from the stomach, pancreas, ovary, or uterus may also occur. The portal vein provides direct access to the liver for the tumors, which is originated from the GIT, and probably account for the high frequency because of the portal vein directly draining into the liver. Now, ultrasound features suggestive of the metastasis. There can be solid, multiple, varying size. There can be hypoechoic halo surrounding it. If the lesions which are target-like lesion, then we can say that, okay, this is metastasis. So, metastasis can be hypoechoic, hyperechoic, isoechoic. It depends on it's coming from whether the metastasis is vascular or is hypovascular or hypovascular. So usually hypoechoic metastases are come from the lung and pancreatic or esophageal tumors, and it also come from the breast. Here in the A image, you can see on the ultrasound, there is ill-defined large hypoechoic mass. And in the B image, again, large ill-defined hypoechoic mass. Now, if we don't know primary, then we can't say this lesion is definitely a metastasis. This can be a primary also. But if we have primary somewhere else and non-primary, then we can definitely say, okay, this is metastatic, definitely metastatic lesion. Now, they can be echogenic metastasis. Echogenic metastasis requires the differential from the hemangiomas. If we know the primary, then that echogenic lesion in the liver is in favor of metastasis more. And echogenic can be from the origin from the GIT, or they can be originate from SCC also. Because they have more vascularity, that's why they look echogenic on the ultrasound. And other echogenic can be metastasis from the RCC. RCC, as we know that RCC metastases are very hypervascular. From the neuroendocrine tumor, they can be from carcinoid, they can be from choriocarcinoma or isolate carcinoma, also tend to be hyperechoic. Here there is spectrum of appearance of hyperechoic lesion with halo. In this, you can say that this is metastasis because this is hyperechoic lesion with hypoechoic halo surrounding it. Hyperechoic lesion with hypoechoic halo. So these are the lesions which can be confidently say, okay, these are the look like metastasis more commonly. But definitely for the final diagnosis, we require the sampling of the lesion and ISC marker for the further treatment plan also. Here in the other images, you can see there is a background cell with multiple small lesions. So they can be primary from the SCC, but also they can be metastatic from the other organ. Especially in the C and D image, you can see there is a large hypoechoic lesion with halo, and they are metastatic from the known case of breast metastasis. Now, metastasis can be calcified also. They are distinct from their marked echogenicity and distal acoustic shadow. If calcification, there can be a distal shadow. Usually, the mucinous adenocarcinoma of the colon is most frequent associated with calcified metastasis. calcium may appear a large echogenic and shadowing foci on ultrasound, and more common show the innumerable tiny punctate echogenic without cleaning shadow. Other primary malignancies that give rise to calcific metastasis are endocrine pancreatic tumors. They can from the leiomyosarcoma, adenocarcinoma of the stomach, neuroblastoma, osteogenic sarcoma, chondrocarcinoma, ovarian cystadenocarcinoma, and terracarcinoma can be calcific metastasis to the liver. Now, finally, cystic metastasis, they are very uncommon and generally exhibit features that distinguish from the benign hepatic cyst. So these are very confusing lesions, but benign hepatic cyst does not have mural nodule, but cystic metastasis can have mural nodule, and by that we can say, okay, this can't be the benign hepatic cyst. This is something to do with some metastasis. And benign hepatic cysts have thin wall, but cystic metastasis have thick wall. They are again fluid filled and they have internal septations. Primary neoplastic with cystic components such as cystadenocarcinoma of the ovary and pancreatic mucinous are often cystic metastasis to the liver. These are the spectrum of appearances of the metastatic lesion. From the top, you can see there are multiple small echogenic lesion scattered in the liver parenchyma. So there are echogenic metastasis. In the B image, you see there is a hyperechoic mass with internal punctate-like calcification with posterior acoustic enhancement. In the
Yeah, I
C
think
image,
you will have to summarize because we are encroaching on other speakers' time.
yes, sir. This is my last slide. This is my last slide, sir.
Just, yeah, please complete it quickly.
Yeah. Thank you, sir. So this F image is a large fully differentiated metastatic adenocarcinoma which shows the tiny internal calcification. In the G to I image, there are cystic lesion with, you can see there is internal mural nodule in it. So we can say that, okay, this is cystic metastasis more likely than benign cyst. Thank you.
Okay, thanks, Dr. Heera. That was a very exhaustive and comprehensive coverage. You showed us a lot of images and told us how to do the ultrasound-based differentiation. I think if we have time at the end of the presentations, maybe we'll
I
come
have
back
some
to a few
questions, but I think we'll move on because it's Sanyukta's time now. Yeah.
Yeah.
Thank you, sir.
So maybe Dr. Kapoor.
Yeah. So next speaker is Dr. Sanyukta Gupta. She is a consultant radiologist with us with expertise in MRI. So I have requested her to tell us that once an ultrasound has been done, when or which lesions seen on ultrasound should be further investigated. Heera, maybe you can stop sharing so that Sanyukta can share.
Yes, sir.
And what are the CT and MRI findings of various lesions? And Sanyukta, if you think you are short of time, then please cover the important lesions, the common lesions. Yeah.
Yes, sir.
Yeah, please share your screen.
Starting my screen sharing. There's some am I
No, we see Zoom.
am I audible?
Yeah, you
Sir?
can hear you, but
Okay, just a minute, sir.
yeah. So Heera, while Sanyukta's screen is coming up, in one line, can you tell us when you would say that ultrasound is good enough and you don't need a further evaluation? Heera? Can you hear me?
So can I get some help from maybe?
At the bottom, there is a green. First, you open your presentation on your laptop.
Yes, that's open there. Yes, sir.
Okay. Now go to the bottom of the screen. There is a green share screen button. Click on that. Or if you are already sharing, then stop sharing. There will be
Okay, I'll stop share. Yeah. then it's fine.
Now share screen again. Yes. Yes.
Okay.
Make it full screen. Yeah.
So,
Go ahead.
good evening, everyone. I'm very thankful to Dr. V.K. Kapoor, sir, for having me here. I'll be talking quickly about the CT and MRI images of common focal liver lesions. And just an overview of my lecture, we'll first talk about the CT and the MRI protocol, which is a basic necessity. If it's not a good quality scan, it's as useless as no definite diagnosis. And we'll further go for the common benign focal liver lesions, common malignant focal lesions, and a bit about LIRADS, which is the newer reporting pattern followed in a cirrhotic liver. So focal liver lesions, as my dear colleague talked about the benign cystic solid lesions, malignant, and the rare tumors on the ultrasound. I'll just talk about the most common ones. So as far as the cystic ones, they were quite extensively talked about in the ultrasound, and I think ultrasound favors a lot more, clinches the diagnosis a lot in the cystic lesions. As far as the simple hepatic cyst, biliary hematoma, or the Caroli disease, polycystic liver disease, a ciliated foregut duplication cyst, various infective causes such as the amoebic pyogenic abscess, hydatid cyst, neoplastic, post-traumatic, miscellaneous. So I'll not be talking about these in details. We'll just see the pictures, but and some of the rare tumors, they can't be covered in a short duration. So we'll just focus so that we can gain maximum from this lecture, and we'll just focus about these few lesions, which are the solid and the malignant lesions. The commonest ones, they will cover about approximately 80% of the common liver lesions we see. So again, this looks a very exhaustive site, and if you're not a radiologist, this just baffles you up and you feel like this. So let's just see if we can do in next 15 minutes or so, can summarize the important details, and you just can get a perfect diagnosis after an imaging. So what is the CT protocol that we need to follow? Is it always a triple phase CT? We just write about a triple phase CT. So we need always a plain CT scan for sure. And this is not like always needed, it is always needed. So we need to distinguish between a fat, calcification, hemorrhage, and which is more better diagnosed on a plain image. We have the early arterial phase, we have the late arterial phase, portal venous phase, and a delayed phase. So early arterial phase is usually mainly an angiographic phase, and if you have a vascular abnormality, then this is preferred. But what is actually a triple phase CCT is comprising of these three phases: late arterial, portal venous, and a delayed phase. So late arterial phase mainly enhances the lesions seen in the liver. We'll see further in our lecture. So when you see the late arterial phase, so basically the aorta has enhanced and the blood has come in the portal vein as well. So this is when you can say this is the perfect late arterial phase taken. So what happens in actually the early arterial phase, you do get the angiographic details about any aberrant vascular, about any thrombosis in the artery or something like that, but you don't know the lesion characteristics per se. So when we go for the late arterial phase, the lesion characteristics can be known very nicely. As far as the MRI protocol, we have the T1 and the T2 images. T1, especially, we have the in and out of phase. What are these images? These are basically for the intravauxal fat. So the lesions containing intravauxal fat will become black on out of phase images, and thus helps you identify the lesion characteristic. Axial T2 weighted fat sat images, this enhances the cyst and the hemangiomas. Diffusion weighted, we all know the sinister ones, the malignant ones show the diffusion restriction, as well as the inflammatory, the abscess. They also show the diffusion. So am I audible?
Yes, please go ahead. We can hear you.
Okay, thank you, sir.
Sanyukta, please go ahead.
Yeah. So as far as the dynamic contrast enhanced MRI is considered, so it is the same as the CT protocol we follow. The subtraction images, what we see and what we call as subtraction is basically if we see any T1 hyperintense lesion. So basically the post contrast MRI taken is a T1 weighted images. So if it a T1 hyperintense lesions, we don't know it's actually per se it was a T1 hyperintense, or after the contrast it has become enhanced. So we need to have the subtraction images for T1 bright lesions. Hepatobiliary phase happens only with the hepatocyte specific contrast. If we have taken that, we have given the patient a specific contrast, then we acquire this phase. MRCP images, obviously, when we have a biliary dilatation and we have to tell us the extension of the lesion. So a little about the hepatospecific contrast. So we have two of them, multi-hands and the EOVIST. EOVIST is not available in India. Multi-hands is what we use, and the phase is taken at about 1 to 3 hours. So the patient needs to sit for a longer time here, and it also, we do not give any other gadolinium contrast. It will acquire all the other dynamic contrast phases as well. So what is important is we have to rule out the pseudo lesions. The lesion is not in the liver, but you are characterizing it as one. So this is the most common one, as Dr. Heera also talked about, this focal fatty infiltration. So this is nothing but a geographical area, and this is not a lesion. It is, the locations are very specific for it, near ligamentum fissure, near ligamentum venosum. So these are focal fatty infiltration, which appears hypodense on CT. Another one, which is, this was a case. So this was a 30-year-old male. As we can see, this is a cirrhotic disease liver. We can see the splenomegaly, the multiple gamma antibodies, and the left lobe hypertrophy. And these are the lesions. This is a T1 weighted image showing a hypointense. This is one which is showing a hyperintense lesion. Multiple hyperintense can be seen in the liver, and we are worried about the HCC. So what happens? We have to project the patient on a triple phase MRI. And what we see on the arterial phase were these vessels at the base of the lesion. These were not any other lesion, but these were vessels which are just arterioportal shunts. This is the hepatic artery draining in portal vein, as because the hepatic vanules have been compromised by the cirrhotic liver. So what happens is the arterial phase itself clinches the diagnosis, and you are sure and makes the patient safe that it's a arterioportal shunt, and he just needs to follow up. So these were non-tumorous arterioportal shunts, and these are the commonest intrahepatic shunts. We just discussed the pathophysiology. Another pseudo lesion, very common, is the THUD, or we also call it as THID. So these are, what are these? These are basically perfusion abnormalities. Whenever a lesion is very hypervascular, or whenever there is a perfusion abnormality, for example, in a cirrhotic liver, for example, in a Budd-Chiari liver. So this is something very hypervascular lesion. So the surrounding lesion, surrounding liver also shows a wedge-shaped, a sharply demarcated lesion, which disappears on the later phases, on the portal venous phases. So this is a transient hepatic attenuation, or THUD, which is arterial phase prominent perfusion abnormality, which is usually subcapsular, a wedge-shaped, a very sharp demarcated lesion, and it's usually in a setting of arterioportal shunts, for example, in trauma, mass cirrhosis, inflammatory, idiopathic, or vascular compression or anomalies. So these the cystic lesions, I'll just skip, as Dr. Heera has talked about them in detail. And these just a few points about it. How do you know that it's a hypodense or a cystic lesion? You have to measure the HU. It helps us many a times, but not always. But less than 20 HU, then you are confirmed that it is mostly a cyst. So you don't project the patient again for an ultrasound to characterize it, whether it's a solid or a cystic. And another entity I would like to highlight is a TSTC, which are too small to characterize lesions on CT or MRI. That's the subcentimetric lesions, which are really too small to characterize, and we can't do anything about them, and we just have to follow it if we are suspecting any in a known primary or somebody. So another cystic lesion which is common is biliary hematoma. This is a classic appearance of it in the CT. Another important cystic lesion is the abscesses. So abscesses do have a thick wall, as we discussed on ultrasound, and we have a fluid or air. So this was a T1 weighted image, and this is a FATSAT suppressed image. And then we go to the phase images, and phase images, what we can nicely see is the edema, and this actually clinches the diagnosis. So So I'll just skip the cystic ones here, and we'll go quickly to the solid lesions, which are the common
Yeah, I
ones.
think come to the important common lesions,
Yes.
otherwise you will run short of time.
Yes, sir. So the case 2 was a 31-year-old female, which presented to us asymptomatic, and it was given as a heteroechoic vascular mass in left lobe. So subsequently, she was projected to a triple phase CT. The hypodense lesion is typically seen on the non-contrast scale. The arterial phase, what we can see is a peripheral discontinuous nodular enhancement, which further becomes a centripetal fill-in on the delayed scans. So this clinches the diagnosis of hemangioma. So we all know about all this. And these are like, if you see 1 to 50%, they are multiple. So just look for the other ones also. So basically, these are an endothelial line vascular space
Your
hepatic artery, and thus this nodular enhancement. So this was a companion case on MR. So this giant lesion with a scar. Now, scar is a peripheral discontinuous with progressive fill-in of the contrast. So these are the atypical hemangiomas. We'll call them giant hemangiomas, which are greater than 6 to 10 centimeter. Now, what is important is we feel that this is a scar, and it should also enhance, because hemangioma finally enhances completely. But as this is a fibro, this is usually a fibroid. Lack of scar enhancement. And the small hemangiomas are also confused with the hysterectomy, right? But it is important as a show of hemangioma. This is a rare one, has So coming further, this was the flash filling hemangioma, T2, very bright lesion. So this is what? This is third, which we just saw. So this is a arterial phase enhancement, and it's persist on the hyper enhancement. So does it look like an hemangioma because it has a peripheral nodular? No, so this is not a hemangioma because this is a continuous filling of the peripheral contrast. Similarly here, this is a rim enhancement, not a nodular discontinuous like of enhancements. So these lesions could be the mimickers. Lesions with peripheral enhancement, you think about that this is the arterial phase, they are taking up hemangioma, but this is the rim enhancement. So these are usually a malignant lesions which show a continuous ring enhancement. Similarly, this is a thing, and this is even showing a centripetal fill-in. So does it mean you have to see the periphery also? The periphery is losing the contrast, and this is showing a very ominous sign, which is called a peripheral washout sign. Enhanced is common, and peripheral washout sign pathology not has to be a malignant lesion. So another case 3, an unusual age for this lesion, but what we saw, I'm just presenting. So this was a case on the arterial phase imaging. The lesion takes up the contrast. This is a 3-year-old boy, and further portal venous phase, it retains the contrast. On the delayed phases, the scar is enhancing. If we see it closely, the scar is enhancing. And we do the MIP image. This is the characteristic feature of a radiating stellate-like appearance of an FNH. So we also did the MR imaging of the lesion. So this was a well-defined lesion with the scar, and on the portal venous phases, it is enhancing. On the arterial phase, it took up the contrast. Portal venous phase, it took up the contrast. Delayed phase, it retains the contrast, but in the hepatobiliary phase, the scar is enhancing. So this was an FNH. So FNH basically has an aberrant dystrophic artery, which imparts the central scar. Now, this scar is usually a tight proliferative response to an aberrant dystrophic artery. So on CT and MR, on the non-contrast, you can barely, the lesion is barely visible to you, and it's homogeneous. On further arterial, there is a bright homogeneous enhancement and becomes ISO on venous and delayed soon. So it becomes ISO on venous and delayed. But on MR, you can appreciate the central scar, which is a T2 dried with the delayed enhancement. These are the basic characteristics of an FNH. The demographics we have talked about, they're more common in females. Okay. So now again, this is again a 35-year-old female, as we just talked about. Are all the hyperechoic lesions on ultrasound hemangiomas? So this was an incidental finding, and the hyperechoic lesion did not turn out to be a hemangioma. This MRI was done, and this is the in phase and the post phase, which rules out the intravoxal fat, and there is a hypo intensity in the periphery, which suggestive of the fat containing lesion. So echogenic lesion on ultrasound is not always hemangiomas. Rarely they can be a fat containing lesion. And similarly, the T2 images, this was hyper intense on T2, but not as not as hyper intense as a sister hemangioma. On the venous or the delayed phases, it loses out the contrast. So fat, it was the fat with the lesions. This was came out to be the adenoma, but this was based on the demographics of a 35-year-old female. That was the first kept diagnosis. Other rare lesions, a fat containing HCC, and other rarer lesions could be angiomyolipomas, and rarely FNH in the setting of a diffuse hepatic steatosis in a obese patient. So this is what I want to emphasize upon, the use of hepatobiliary contrast agent to distinguish between FNH and hepatic adenomas. So FNH usually is made up of hepatocytes, so the hepatocyte specific contrast is taken up by the tumor itself, whereas in the setting of this last images, the first top row is FNH case, and the second top row is the hepatic adenoma. So in the arterial phase, both of them, venous phase, that retains contrast, the FNH, and on the hepatobiliary phase, it's brilliantly enhancing with a spoke-like, and we can even see the internal architecture on it. Whereas the adenoma loses out the contrast, and in the hepatobiliary phase, it does not retains the contrast. So teaching point of women on OCP, a diffusely enhancing mass that does not meet the criteria for FNH, and it is more heterogeneous. So the FNH, it seems to be more homogeneous rather than a adenoma, which is more heterogeneous. Both of them are arterial enhancing. So we have to think of hepatocellular adenomas, which DD may include FLC, HCC, as we'll further see. So I'll further go with the adenomas. These are the three main types pathologically, and there are slight characteristics on imaging also, which can even differentiate between these. But I think the time does not permit me to show more of these. So we'll stick to next entity. Hypervascular liver SOL with the central scar. We just saw a lesion with that. That was FNH. So is it diagnostic? The FNH has a hypervascularity and a central scar? No. So let's see. This was a 22-year-old female with an incidental mass. So this is a pre-contrast MRI with a scar, and this is the hepatic arterial phase with enhancement, with the portal venous phase losing out the contrast, and the delayed phase completely losing out the contrast. So, but the if we see the CT, we could see the calcifications. And even on the triple phase CTs, the lesion loses out the contrast. So this was FLC variant of HCC, which is an uncommon variant of hepatoma, can be FNH.
Sanyukta, you will have to finish in another 3 minutes.
Okay, sir. So this is the same population, same patient population. So it looks like FNH, but it's too heterogeneous. So we have to think of fibrolamellar HCC. Another next entity we'll talk about, this is the arterial phase hyper-enhancing lesion, but look at the enhancement. This is a rim-enhancing lesion, not a peripheral nodular. And what we can see is a capsular retraction also. Now this clinches us the diagnosis. The lesion contains some fibrotic component. And on the delayed images, this is showing a peripheral washout. So the viable tumor lies here, and the unviable or the fibrotic component lies here. And this is what the imaging characteristics show us. So these are the capsular retraction. This was came to be a intrahepatic cholangiocarcinomas. So the peripherally has the viable tumor, and the dense fibrous stroma is at the center. So we can also, this has a characteristic feature on the diffusion also, showing a targetoid appearance. This is again the viable tumor showing the diffusion. So this was a targetoid enhancement with rim arterial phase hyper enhancement on the art, but on the much delayed phases, it has a delayed central enhancement. Another very important component is the cirrhotic liver. How do we diagnose the HCC? So HCC has a typical pattern of enhancement. A hepatoarterial phase, it does take enhancement, but it has to be a non-rim arterial phase hyper enhancement on which washes out in a portal venous phase and which retains a cap. If it's a 2 centimeter or more arterial hyperenhanced mass in a cirrhotic liver that washes out and has a capsulitis diagnostic of HCC. So this was a case we encountered. And so T1 also shows some hyperintense areas. So these hyperintense areas can either be fat, can either be hemorrhage. So this does not drop on opposed phase images. So this was considered as a hemorrhage, and this was the lesion. So lesion is taking up some contrast in arterial phase, definitely, and is losing out the contrast. So this was a cirrhotic liver. So in the picture of a cirrhotic liver, and it's showing HCC. So we'll talk about these enhancements in detail. This looks again an exhaustive slide. I'm nearing to my end of the lecture, but I would just like to emphasize upon the enhancement patterns, which helps us clinches the diagnosis. So the peripheral discontinuous becomes a very characteristic of hemangiomas. The mosaic what we can see here, the three enhancement type characteristics, which are very sinister type of ring enhancement. That is a ring enhancement, which is almost always either a inflammatory pathology or cancer, metastasis, or HCC, ICC. And then we have a target enhancement that's usually a metastasis, and a mosaic enhancement, which is usually a HCC or FLHCC. What we have to differentiate between are the hypervascular lesions on these triple phase MR and CTs. These are the FNH, HCA, hypervascular degenerative nodules, HCC, FLHCC. We just talked about each of them. And the peripheral washout sign, which is very particular of the malignant lesions. So if we know the enhancement pattern of all of these, rim enhancement lesions, mild diffuse, with the help of the history, with the help of the delayed or the hepatobiliary phase, we know when to take which phase, with the help of the T2 and T1 signal, with the help of the scar and the fat or the calcium content, we can make a diagnosis. So we just have to tell the clinician, I suppose, don't touch me lesions, the biopsy or the further imaging lesions, and which are the suspicious for malignancy, or you are very much sure that these are definitely a malignant lesion. So we again a bit about the LIRADS. LIRADS is usually done in a cirrhotic liver. How to manage those there is this continuum of the nodules, dysplastic nodules, low grade, high grade, early HCC and HCC. These are we talk about definitely probability, probably HCC, definitely HCC, LR5. So this is again, we have to consider the three characteristics, mainly arterial phase hyperenhancement, the size, the enhancing capsule, the non-peripheral washout, the threshold go. This is again a very
I think I'll have to interrupt and stop you because
this is my last slide. Like, okay.
Et même à supposer que mon école un étranger, mon école un français, également les lois du pays dañuy appliquer ci moom. La preuve, fi mu toll.
See, just a comment for both of you that you gave very detailed radiological description, but you have to understand that this is a surgical masterclass. So I will ask very straight, pointed questions because we don't want to encroach on Dr. Gambhir's time. Am I audible?
Yeah, go ahead.
First question is, after doing an ultrasound, if it is a cystic or a solid lesion, when should we proceed with a CT or MRI? And if we should proceed, when should we do CT and when should we do MRI as the first investigation? See, all these are detailed radiological findings which are very good for a radiological audience. But from a clinical point of view, these are the questions which I would like. So quick answers, 1 minute answers from both Heera and you. which lesion on ultrasound we can stop at ultrasound, and which should proceed with CT and MRI, and if yes, whether CT or whether MRI as the first investigation.
Can I also add on to that? Can you replace CT with a contrast enhanced ultrasound? Is that better? So that also, if you can
Quick
either.
answers. We just have 3 minutes. Heera.
Hello.
Yes.
Yeah, so first I'm coming to the Kapoor sir's question that in which lesions we should go further for imaging after the ultrasound, which we should stop. So I would say that in the benign lesions, specifically the patient does not have any background liver disease, patient does not have any other primary lesions, and if this lesion is solitary cystic small lesion with imperceptible wall, then we should stop. We can follow up the patient. Okay, that this is definitely confidently cyst. So for the solitary small simple cystic lesions, we do not require any further imaging. Now, if patient come with some background CLD, if patient has a lesion, solid, whether is it 2 centimeter lesion, is 5 centimeter lesion, solitary or multiple, definitely we require triple phase CT scan for those patients. Again, if patient has normal background liver and a solitary lesion, a well-defined lesion, then we can have follow-up. We do not require any further imaging for those patients. Like for example, hemangiomas, definitely we can confidently say this is hemangioma, except some metastatic disease. Definitely, patient have metastasis, they have already diagnosed primary diseases, so we require CT scan for them, or MRI if the patient few lesions which are not diagnosed
We
on
have
the.
1 more minute, Sanyukta. If we have to further investigate after an ultrasound, what would you prefer? If available, contrast enhanced ultrasound, a triple phase CT, or a contrast enhanced MRI?
So in the cystic lesions.
No, whatever lesion we have seen on, let's talk of solid because cystic is a little easier. Solid
Yes.
lesion on ultrasound, we want further investigation. What is the choice further?
MRI, as per the studies, this is more sensitive. We tend to take more dynamic phases, and the lesion characteristics can be identified more easily on MRI.
Okay, I think we will have to move on because it is 8:30, and that is why I insisted that we should leave enough time for discussion, because there are so many questions which need to be asked, but we don't have time. So maybe Dr. Saraswat, you can introduce Dr. Gambhir and we can proceed.
Hi, good evening, Gambhir. Can you turn your video on? Dr. Sanjay Gambhir is somebody we have known, I think, since the late 80s, early 90s. All three of us go back to that era at SGPGI. He is the chief of nuclear medicine now at SGPGI in Lucknow, and is a very eminent figure in nuclear medicine circles. So I think a detailed introduction will probably eat into his time, and Gambhir will be much happier covering the topic that we have, because after having done axial and ultrasound and contrast enhanced CT MRI, what exactly is the nuclear medicine option offering to the clinician is something probably there can be few people better fitted to answer this question than Dr. Gambhir. So Gambhir, the floor is yours. Please go ahead.
Yeah. Good evening.
I think people can turn off their microphones, those other than Dr. Gambhir.
Yeah. So my Zoom app on the computer is, there's a echo, lot of echo.
Yeah, actually, echo, is there a second thing on? Your mobile is also on. You might be logged on onto 2 devices.
I am, as my computer mic and Zoom video is not working.
नहीं तो एक का आप म्यूट कर दो, बिकॉज आपका इको हो रहा है आवाज.
वो तो म्यूटेड ही है.
नहीं, अभी मैंने म्यूट किया है. आप
No, you can't hear him.
Comme est-ce qu'elle a bénéficié d'une résection segmentaire du côlon gauche avec la seconde
somebody
diapo suivante.
सर वो म्यूट हो गए सर, आप उनको अनम्यूट कीजिए।
इसको
सर जिनको आप अनम्यूट करें सर, उनके पास एक डिवाइस और भी है जिसपे कि वो ऑन है, वो हमारे
संजय,
पास
आप अनम्यूट करिए अपना। नहीं, आप आईफोन वाला अनम्यूट करो।
हाँ, यस।
नहीं, आपका ना इको हो रहा है, आपको एक कोई म्यूट करना पड़ेगा।
वो तो कंप्यूटर वाला तो अनम्यूट ही नहीं हो रहा ना।
सर आप उसको लॉग ऑफ कर दें कंप्यूटर वाले को सर, कंप्यूटर शट डाउन कर दिया था आप। अच्छा, दिक्कत आपका पीपीटी कंप्यूटर में होगा आपको।
We tried with Himanshi. I was trying in background to solve this, but somehow we reloaded again many times.
We'll put up with the echo, Sanjay.
चलिए करिए, let us start.
करिए।
Yeah, we will manage. Yeah.
So let me share the slides. So can you hear me?
Please make it full screen. Yes, we can see. Please carry on.
So it's tough.
बहुत ज्यादा इको हो रहा है।
सर आपके कीपैड, सर आपकी कंप्यूटर के कीपैड पर एक माइक वाला ऑप्शन होगा सर, उसको म्यूट कर दें वहां से सर, कंप्यूटर के कीपैड पे सर, या लैपटॉप के कीपैड पर।
टॉप रो में एक माइक वाला होगा, उसको माइक करके देखो।
Does it help?
Yes sir, better.
Is it okay now?
I think it is better. Yes. हाँ, ठीक है, good.
Okay. Yes. So the at computer both the buttons are not unlocking, the mic and the camera too. Anyway, I guess that's why I'm on two gadgets. I've heard a lot about the anatomical thing, and that's the predominant imaging thing for all space occupying lesion. So as far as nuclear medicine is considered, I was asked to talk about scintigraphy and PET. So scintigraphy consists of, basically when we said scintigraphy, we mean technetium, our standard gamma camera imaging with technetium agents. So there was a time when is there echo again? Okay. So when there was this standard liver scanning with sulfur colloid was used for the liver imaging for the space occupying lesion, and then the RBC imaging was used for the focal nodular hyperplasia and liver hemangioma. Are the slides moving? Can you?
Yes. We can see the arrow.
So these were the some agents, sulfur colloid and RBCs, and macro aggregates for shunts, and for accessory spleen also the heat damaged RBC, they are still talked about occasionally. So these are the 4 standard scintigraphic agents for various indications, as you said, for the hemangioma and for any space occupying lesion. So the sulfur colloid basically goes to all the parts, the spleen, the liver, the bone marrow, and all the reticuloendothelial system. So the colloid was earlier used, it shows all the reticuloendothelial system and thus gives a shadow of the dark shadow of where it is taken in the liver, spleen, and you can see the bone marrow. That means all the things are working well, the reticuloendothelium is working nicely. And in this background, if there was a SOL, that came up as a coin negative shadow in this liver. So in the era when the ultrasound was not there or was just coming in, when I was in Mars DRDO, that was the only ultrasound in whole of Delhi. So at that time, if ultrasound was busy, more than half of the SOLs would land in nuclear medicine to show that there is a SOL. Not to characterize further, yes, there is a SOL, and that's where when we all use sulfur colloid to look for a negative shadow in a dark colloid background. And colloid, just to update, also give you function that the liver is functioning well. If the uptake of liver is more than spleen and marrow is seen, that means all the parenchyma, the Kupffer cells, the reticuloendothelium. So it gave you about the function of the liver. And if there is any negative shadow in the liver, that means some SOL was there. That's all we could do. But still at that time, this was very popular. Now, this is no longer required in the era of ultrasound, CT scans and all. So just for recapitulation. And then there came the RBC scan, which was earlier done, suspicion of liver hemangioma. So these characteristics of hemangioma, which are now talked about in ultrasound and CT, the perfusion phase and the arterial phase and the later washout phase, that was the standard thing which started in nuclear medicine. And that's how we detected hemangiomas. We injected labeled RBCs and it would go in the hemangioma, stay there, whereas the liver background would wash off. So it would give a positive coin-shaped lesion, single or more than one. So very characteristic of the features of hemangioma. And because hemangioma was part of the group also, whether it is benign lesion or malignant, so hemangioma would rule out malignancy indirectly. So these are histological thing, and I would skip because a lot has been discussed. And so what I would do, so in ultrasound hyperechoic mass, no Doppler sign, slow flow in the liver. And that's when, is if you compare with the nuclear one, I would straight come to it. The gradual centripetal enhancement of the portal venous phase and the peripheral nodal enhancement in the arterial phase, as was just discussed, even in the MRI. So that was starting point of it, even in the technetium labeled RBC, which was used as a contrast to enhance this image in the early phase and in the mid phase and the late phase. And they showed up very nicely in our image. I'm trying to skip to the image because all this has been talked already. So if you see that the features, the below the two images are the perfusion phase on the labeled RBCs. So what you see as a big lesion in the liver, that in the planar nuclear perfusion phase, you can see all the vessels, and the heart you can see in the upper half, in the chest. So the lower part of the liver is enhancing with the labeled technetium labeled RBCs, and the upper part of the liver is not enhanced. So the labeled RBCs they show that they are pulling in this lesion, which was they shown in this case in CT, or if seen on ultrasound. So and this enhancing of the liver and then retention. So this is the perfusion, the border two images, and then it would sort of enhance. The rest of the liver would come up, and then that part slowly would wash out. So in this studies, what was shown at that the sensitivity is still very high, 97% specificity, 83%, accuracy is very high, and there was only perfusion, slight change in the perfusion and blood flow phase to discriminate that what type of hemangioma it is. So this is just I have put it to show this is where the hemangioma perfusion and various phases started, and this is still a very good technique. So if there is any controversy, confusion, or equivocal thin or CT or MR, then this can be still be resorted to, though the referrals are now very less, but the technique is very stable and sound. So the sulfur colloid is off, simple SOL, and the hemangioma thing is still very much based on very nice principles, which were later adopted to better anatomical imaging techniques like CT and MR. So basically, this phases came from here, and this technique still is valid and holds good. So that is the point to highlight it. So in general, 90% sensitivity, the larger the lesion, the better the accuracy. And then came the SPECT, the single photon emission. So we can get the sections of the liver like CT. Now we have SPECT CT. So if you add SPECT CT to the same planar imaging, the sensitivity goes very much high, more than 90%. And the size, and so negative ones we have difficulty is if it is adjacent to a vascular structure like heart and hilum or great vessels, or some fibrosis is there. So you can see the false positivity is, just 5%, and there are more of false negative. So here is the list, the other things where there can be overlap, but not so much, are the other kind of masses, generally in the liver, where there can be some overlap. So SPECT improves the sensitivity, better localizes which lobe of the liver, which segment of the liver the lesion is, and whether it is separated from the. So in this case, the upper part, the below the dome of the diaphragm, you can see this nice mass. And in the transverse section, in the SPECT images, you can see this coming, this lesion, and this is the spleen, the dark one, and there is a, this is the perfusion phase on the SPECT one, where it is very faintly seen, and as we go along, this would further enhance. So this is again in the SPECT images, you can see very nicely bright and shining. This is large one, and it is superimposed on the CT of the SPECT CT, so you can see which segment it is. So these are examples of various studies where the percentage of detectable lesion was there. So these studies were being done till 2004-5, and occasionally patients are still referred to us. Another case, nicely seen lesion near the hilum in CT. This was hypodense, and then it enhanced in the, and liver washed out. You can see liver becomes faint, and this lesion shines nicely, and you can very well. So this is RBC technique. So these two techniques I wanted to highlight to recapitulate the sulfur colloid and the hemangioma RBC level SPECT, which is very much valid, though more of the referral because of good anatomical delineation is going to the MRI or the CT part. So I will now come to the FDG, the other, this is the PET. So the task was scintigraphy at the PET. So scintigraphy is just these two techniques, which are little bit in vogue today. And the other rest of the things have gone to the PET. And PET, as you know, is retained in the cells, in the normal liver cells. And if you have SOL in the liver, depending on the kind of cells. So FDG PET per se is not for detection of SOL. It is to characterize in case like you have done such extensive studies on the CT and MR, and if still there is a query and you are still not going in, not sure of putting in the needle to get your sample. So in that scenario, FDG helps to characterize that mass, what kind of mass it is. Basically, it is a glucose substrate which is upregulated in more in malignant masses, less in inflammatory masses, but goes both across the malignant to inflammatory masses. So there are false positive also. So in this, the retention, the reasons of retention is there. Apart from the glucose upregulation, the other important thing is the turnover is based on the proliferation of the cells which are in that mass. So there can be same histological character to the mass, but two masses are not different because cells would be proliferating different. What it means is if there is a poorly differentiating mass, poorly differentiated hepatocellular carcinoma, so in that case, the uptake of FDG would be quite high. So SUV, what we get the cutoff values, standard uptake values, they would be 7 or 8 and very clearly visible to blind eye. So if it is moderately differentiated or well differentiated, the uptake of FDG would be much lesser. So there is a variation across the same lesion. So if a SOL is coming and you are trying to make out what it is malignant or not, this is one way to go, realizing that the uptake would be still be variable on the inherent and stage of that SOL. Is it the cell dividing very fast, slow? What is the size of the lesion? But grossly the principle is that if there is more FD uptake, the probability of it being malignant goes up. Now, the uptake also indicates the prognosis too. If the uptake is high, that means it's poorly differentiated. So it is be little difficult to tackle. And if you are trying to be aggressive, that might not be the way because it's unlikely to respond or respond poorly to the treatment you are planning, even chemo or surgical or what. So the recurrences will be more. So in hepatocellular carcinoma, HCC sensitivity detection is 50 to 70% because of this varied uptake across the same lesion, whether it is poorly differentiated or intermediate differentiated or very well differentiated. So poorly differentiated, I have already told you will have high SUV. And the other thing is good to give you simultaneously information about the extrahepatic extension, metastasis, or you want to follow up that disease after treatment intervention. So when you are doing FDG in for a characterizing a lesion in the liver, that will give you indication how aggressive the mass is likely to be with good probability. And then it gives you a template for follow-up of your patient as to did it simultaneously have the lymph nodes too, or the therapy you give, whether the uptake goes low later, that means there is a response to therapy. So it's a comprehensive in the sense to characterize the behavior of the tissue and what it is. So, and of course, here is an example of hepatocellular carcinoma here in the lobe where the pointer is, and simultaneously there are two lymph nodes. So this clearly tells you that it is a metastatic lesion. So you can, fuse the image and decide on the further course of the. So it has staged the disease for you. It has told you it is a malignant disease. And if, of course, histopathological diagnosis is required, one goes in and still puts the needle. There are other newer agents of 11 carbon which we make with the cyclotron. So at times FTG does not go. So you shift to the amino acid labeling. The amino acid, we have methionine and we have acetate and we have choline. Now this is 20-minute half-life. I just wanted to point out that if you have still doubt, then you can shift to amino acid PET agents which are still giving you another step forward that this lesion is having very aggressive turnover of metabolism. If not glucose, the amino acid uptake is very sharp and high. Now, I mentioned this because the 11 carbon is 20 minutes half-life. It can be done where only cyclotron is there, like we do at SGPGI. But now the vendors are giving the F18 version of these agents also. So like you buy your FDG, you can buy the not 11 carbon, but F18 choline from a vendor and put it to see that your lesion has a amino acid turnover. So it is a further one step further backup of FDG. If FDG is equivocal, you can shift to the amino acid with the same aim as to characterize these into malignant and the non-malignant variety. So basically, we've seen various classifications in earlier lecture, ultrasound. So malignant and benign and this. So this list is long and very characteristic features of hepatocellular adenoma were just told, or angioma. So basically, this, as I put in red at the majority of primary and secondary malignant lesion show high uptake. Though the variation is large, still they are to large extent will give you a very strong indication. And apart from that, the benign one, the lymphomas or angiomyolymphoma, focal nodular hyperplasia, and in our country, the infections and inflammation, including the autoimmune processes, they will show patchy uptake in the FDG PET if you happen to do it, or is it incidentally detected while PET was being done for some other cause, then you have to chase that lesion as to what it is. It is not matching with the primary finding or the primary disease you were following up the patient for. So the uptakes and inflammation, we do see it in tuberculosis. In our country, tuberculosis is quite common. We see it in lymphoma. We see in children, any immune depressed. So there are simultaneously benign infiltrations or inflammatory masses in the liver, which appear as well, but they are inflammatory. So the more aggressive uptake is in the malignant lesion, but at times these inflammatory lesions do overlap with these malignant. So one has to be careful. At times these two lesions appear together. There is a metastasis from colon, and then there is a tubercular lesion also. We have seen that. So there the overlap is there. So one would still have to put a needle there to differentiate between these two things. So there are benign tumors which take FDG, and there are malignant one with much force on the malignant side. So the uptake, as I earlier said, there are GLUT receptors.
Another maybe 2 minutes.
Right. So we forget about the mechanism. So the cellular turnover and how the uptake mechanism is regulated in each cancer type leads to the increased uptake, and that tells us about the characteristic of the tissue. So in summarize, with the advent of new techniques, sulfur colloid is no longer in vogue, and for liver as well, and hemangiomas can be done with good sensitivity and specificity with technetium labeled RBCs. FDG is for characterizing the SOLs of the liver, extrahepatic disease staging, recurrence, follow-up, and equivocal cases from MRI falling over, and guiding biopsy. We at times get call from radiology group where their enhancement in the standard triple phase in CT or MRI is not there, but they are suspecting on ultrasound did show some change in ultrasound signal. So they feel. So this happens in the infiltrative kind of mass, lymphoma, breast secondaries, and some other diseases, and even in tuberculosis also. So there is a plate-like or tree-like extension of the cell. So they are not exactly a mass. So their signals are different. So you need to do a biopsy. So at times FDG does shows uptake in such kind of mass. Yes, there is a mass in the liver. So you can target your right area where to do your biopsy from. And of course, if you are doing in context with the carcinoid and other neuroendocrine region, the gallium octreotide and dotatate is support to show that the mass in the liver is from these malignancy, and you can take help to back up the standard FDG may be low, in these things, whereas the octreotide or dotatate may be quite high. So that's what from me. Thank you very much.
Thank you. We have to close at 9. So concluding comments from Dr. Saraswat and Dr. Mehta.
Well, I think we have had a very elaborate presentation by each of the imaging presenters, all three of them, and a lot of information has been given. I think time for question answer is crucial for a good session, and we are probably been starved of questions in this session. I think Gambhir, a quick question for you would be: you mentioned SUV max values, and we know that severe inflammation versus neoplasia are the two pathologies we are thinking. So, is there some kind of an SUV max cutoff that can help to differentiate between what is probably inflammatory versus neoplastic?
There are no, this is very frequently asked question. So there are no official cutoffs or guideline which call for. There are gross experience based that usually above 6 is more likely to be malignant, and below that, as you come below that, they are unlikely to be. But that's not the rule of the thumb, right? So that's what we say. Oh, so you have to correlate with your other kind of clinical backups or other biomarkers which are indicating whether it is inflammatory or that. So all with that stage, we can say there is a lesion and it can be both.
Okay, thank you. So I think maybe Professor Mehta can put in make his comments and complete the session. Thank you.
I would like to congratulate all the 4 speakers. They have done a fantastic job. Tried to cover a very vast and a comprehensive presentation and on a topic in a very short span of time. But as already said, it is always better to have a short time period left for question and answers, because the students who are attending this session may have some queries. Unfortunately, we don't have any questions coming up on the chat, but that would have made it a little more livelier. But nevertheless, I think all of you have done a fantastic job in trying to cover a very vast topic. So thank you. It was a fantastic masterclass.
Anand, you are there. You want to conclude and announce about JST? Is Anand there? Because he had to leave in between actually for emergency. So if he is not there, then I would like to thank all the 4 speakers and Dr. Naimish and Dr. Saraswat. So we will continue with the masterclass tomorrow, 7 to 9 again, and cover the rest of the things.
Thank you, sir.
As is our tradition, we start at 7 and close at 9. So good night, everyone. Thank you. Thank you very much.
Thank you.
Okay,
Good night.
Bye-bye.
Thank you.
Enjoyed that.
Thank you.
Yeah.